So really what my talk is really the introduction for the real talk, which is will be given by Dr. Imlay at the after my talk. But it's about immunosuppression and the current experience we've had with managing the COVID transplantation and immunosuppression in COVID transplantation. We still don't know much of what we're doing, but nevertheless, I could gather from the literature some of the pearls that we have been able to have, over the past year or so since the epidemic started. So let's do that. Okay. So, I mean, I don't have to tell you that SARS-CoV-2 has spread over the entire United States, and this is the heat map as early as December. Every single county, every single city, every single place in the United States has been affected by COVID-19. These are the stages of COVID-19 disease course, three-stage classification: stage 1, stage 2, stage 3. Stage 1 and 2 mostly dominated by the viral response phase, but stage 2 and 3 dominated by the host inflammatory response phase. The stage 1 is the one where you have some symptoms, mostly constitutional symptoms, and how can I? And just okay, that's good. And stage 2 is where you have the pulmonary phase, where if you move to stage 2B, it's when you have really bad hypoxia and the need for oxygen supplementation, and followed by the stage 3, which is really the one that leads to a lot of the complications of COVID, which is the host inflammatory response. And I won't belabor those things. So as far as the impact of COVID-19 on solid organ transplant, there are still many unknowns and concerns in transplant recipient. What's the infection rate? What's the diagnostic yield of the PCR testing in the transplantation? Is the clinical presentation different than in non-transplant patient? What is the efficacy and resistance to antiviral therapy? And what are the outcomes? What's the morbidity, mortality? Is there an increase in rejection episode? What are the long-term consequences in solid organ transplant? What is the incidence of secondary or superimposed infection? And very importantly, what's the impact of baseline immunosuppression on the risk of severe disease? These are still unknowns, and I'll talk a little bit about them. Now, the risk of COVID-19 are heightened for organ transplantation, and based on the previous experience that we have with respiratory viruses in transplant recipients are more likely to have a greater susceptibility to acquire the disease. They are more likely to have a rapid progression to pneumonia, COVID pneumonia. They are more likely to have greater disease severity. They're more likely to develop bacterial or fungal superinfection. They're more likely to have prolonged viral shedding, which could increase transmissibility. And immunosuppression appears to be a risk factor, obviously, for the infection and for poor outcomes in transplant recipient. In addition to that, organ transplant recipients have a high prevalence of comorbidities that are already known comorbidities as risk factor for severe disease in COVID-19 patient: diabetes, obesity, all the other hypertension, all the other known comorbidities. Now, what happened when the pandemic was declared? What we see here in that graph, that the number of deceased donor organs on this side of the graph, on the left side of the graph, is the number of deceased organs transplanted in the US by week. And we see that there was a dip starting mid of March into April, and then a rebound after that in May. But the biggest dip happened in living donor kidney transplantation. So the declines were more pronounced in living donor transplant than deceased donor in both scale and also duration, for the duration of which they didn't rebound really back until the summer of 2020. Now, the initial reports pointed to a high morbidity, to high hospitalization and mortality in those transplant recipients. These are some of the early reports: 25% in hospital mortality, 28% mortality, 24% in hospital mortality, 52% ICU mortality by different publications. Oops, go back. Okay. This is the outcome of hospitalized transplants versus non-transplant patient diagnosed with COVID-19. This is the early experience from Henry Ford Hospital, a cohort of patients, small cohort of patients from March 20 to April 18, 2020. And what was observed, and these are the number of patients. There were 38 kidney, 5 heart, 4 lung, 1 liver, and 1 pancreas. And what they found that the hospitalized transplant patient and non-transplant controls had comparable ICU admissions, comparable mechanical ventilation, and death. But the difference between them was there was a higher incidence of acute kidney injury in the transplant population, a higher incidence also of acute kidney injury requiring dialysis or other forms of renal replacement therapy in those transplant recipients. The mortality rate was high among hospitalized transplant recipient compared to non-hospitalized transplant recipient. And this is in a larger study. This is actually the registry that is from the University of Washington that was published online by Cates, which has done a remarkable job. And Dr. Imlay may know her. She's a senior fellow at the University of Washington who has compiled all this data. Now, the mortality is the highest in those transplantation who have increased comorbidities. So among the hospitalized transplant patients with COVID-19, the 28-day mortality rate was 20.5%. And those mortality that were associated with, those morbidity that were associated with mortality was age, with a 3-fold increased risk of mortality, congestive heart failure, 5-fold increased risk, chronic lung disease, 5-fold increased risk, diabetes, 2-fold increased risk, and obesity, almost 2-fold increased risk. But interestingly enough, the transplant-related immunosuppression was not associated with an increased risk of mortality. And that's very important to note. So this is another study that looked at the risk factor for poor outcome in the transplant population, similar to the general population: age, diabetes, hypertension, coronary artery disease, obesity, not immunosuppression. Disease severity was similar regardless of the organ transplantation, whether it's early versus late transplant, and regardless of the immunosuppression used. And as far as secondary outcomes, some of the unknown became known. There was no increased risk of infection, secondary infection, and there was no increased risk of rejection also. The baseline immunosuppression had a neutral effect overall in those reports because the risk of increased viral burden was balanced by subsequent blunting of the inflammatory response with the use of immunosuppression. So although there was more viral burden because of the immunosuppression, there was blunting of the phase 3 that I showed you, which was inflammatory response, which made the two effect neutral in a sense. Now, obviously, there are many limitations that are available to those data. Most of them are retrospective. Most of them are single center studies, with the exception of one, which is the University of Washington Registry, which compiled data from all over the country, which will actually prove to be very useful in subsequent follow-up. And again, most data are first wave disease data. And also, we have to remember different parts of the country had different access to medical care and different access to treatment. And also, from a time-wise, we became a little bit better in treating those patients as time went by. What's the impacts of specific immunosuppressive agents? Overall, limited data. We know that corticosteroids are beneficial. After all, if you look at the graph here, we use dexamethasone as our standard of care nowadays to decrease mortality in all the COVID patients. But interestingly enough, what we know in vitro is that MPA inhibits SARS-CoV-2 replication in vitro. And also, mTOR inhibitors have the potential to control viral particle synthesis and to blunt cytokine storm. So not so bad, right? And interesting enough, there was this study that was done in liver transplant recipient with COVID-19, 243 liver transplant recipient across Europe, 25% mortality. And interesting enough, those who were receiving TAC was protective against mortality in this liver transplant cohort. And it's thought that CoV replication depends on active immunophilin, FK binding protein, and that it tends to inhibit pro-inflammatory cytokines, TNF-alpha and interferon gamma, which tend to play a role in phase 3, which was the inflammatory host response. So next step was, how about induction immunosuppression? We all rushed at the beginning of the epidemic to decrease the use of induction immunosuppression, thinking that it's going to be bad, And so What this study, which was a national SRTR registry study, which was published recently, reviewed the induction immunosuppression for transplant recipients and compared them to the pre-pandemic era. So they had patients in the pre-pandemic era controls that were about 65,000 patients, and in the pandemic era, which was between March 13 and July 31, there were about 5,000 transplants. So those were compared to the pre-pandemic era, and the primary outcome was the use of lymphocyte-depleting agents for induction immunosuppression and steroids for maintenance immunosuppression at discharge from transplant admission in the pre-pandemic and pandemic eras. And overall, the use of lymphocyte-depleting agent was lower in the pandemic era compared to the pre-pandemic era. And also, and that's because of the fear that we had about the use of those lymphocyte-depleting agents. And in the pandemic era, the lymphocyte-depleting agents were associated with numerically lower odds of acute rejection, similar to the pre-pandemic era. And there were also similar rates of death during admission compared to the non-depleting agent or no-induction. So the use of lymphocyte-depleting agent, more acute rejection, similar rates of death, similar rate of, and also I'll show you similar rates of delayed graft function, which I'll show you that in a different slide. But the effect of no induction versus induction and the effect of depleting versus non-depleting did not matter really as far as outcome. As a matter of fact, these are the odd ratio of acute rejection during admission, of death, of delayed graft function, of graft failure. And these findings did not support the strategy that was adopted early in the pandemic era, that a decrease in lymphocyte-depleting agent, that was the theory, would be a safe and effective strategy to mitigate the novel infectious risk. It didn't turn out to be the case. It didn't make a difference, really. Overall, like I said, so in summary, overall, there was a decrease in the use of anti-lymphocyte antibody, but no change in the incidence of acute rejection episodes, no change in the incidence of patient death, no change in DGF, and no change in the incidence of graft failure. Nevertheless, the American Society of Transplantation came up with some guidelines, recommendations that, and it stated the following, that decreasing immunosuppression should be considered for infected recipient with no recent history of rejection episodes. Many providers have decreased or discontinued cell cycle inhibitors or reduced calcineurin inhibitor levels, but comparative data regarding these interventions are not yet available. As a matter of fact, they're showing that it doesn't really make a big difference. The recommendation of the ASC was the decision to reduce immunosuppression should be based on the severity of the COVID-19 disease in comparison with the risk of rejection, and patients receiving maintenance corticosteroids have generally been maintained on these during therapy for the disease. If anything, the dose was increased most of the time. Now, how do we compare that to the risk of being on the waiting list or not yet, not receiving kidney transplant? This was a single-center study that looked at the outcome of COVID-19 patient waitlisted for a kidney compared to those of transplant recipient. And clearly, the overall case fatality was significantly higher among waitlisted patient versus transplant patient, 34% versus 16%, meaning that it's better to have received a transplant than remain on dialysis and being waitlisted. They were also more likely to require hospitalization, 82% versus 65%. So understanding the impact of COVID-19 on waitlisted patient versus transplant recipient will aid the centers in weighing the risk and benefit of transplantation. In a sense, in this case, meaning that transplant would not increase the risk of mortality. If anything, being on the waiting list increases the risk of mortality. Obviously, there are ongoing studies, ongoing registries, some of them throughout the United States, some of them international, and these will come out and will give us more information. But very importantly, we have mitigation strategies that we've employed during the pandemic, such as telemedicine visits, remote education, care coordination, designated units for suspected positive versus asymptomatic negative patient, and all these have helped a lot. So in conclusion, transplant recipients are profoundly impacted by COVID-19. Baseline immunosuppression does not appear to be an independent risk factor for poor outcome. Obviously, there is a critical need for further studies. The optimal management of immunosuppression during COVID-19 remains not very well defined. because it's a complex equation involving viral control, inflammatory response, and risk of rejection. There is some consensus on reducing cell cycle inhibitors in the setting of severe symptoms, but prevention remains the major risk, the major risk mitigation strategy. And obviously, there is an urgent need to investigate the safety and response of vaccination in transplant recipient, which brings us to the next topic by Dr. Imlay. So I'll sign out at this stage and give the podium to Dr. Imlay.
Thanks, Fuad. Before Dr. Imlay, any questions out there people want to speak up to, or just enter into the text chat? And we can come back to those at the end as well. But if you've got questions right now while Dr. Imlay is pulling up her material, please enter those. And I'll introduce Dr. Hannah Imlay. She's an assistant clinical professor in the Division of Infectious Disease and one of our transplant infectious disease specialists. She arrived at the University of Utah in 2019. Good timing, just prior to pandemic. So we're really happy to have her here today presenting on COVID-19 vaccine in the pre and post-transplant population.
Thank you very much for the introduction. And thank you everybody for having me. Should I go ahead or do you want to wait for more questions?
Looks like there is a question real quick before we begin.
We do have a question. We do have a question from Erica. She is asking, so in your opinion, looking at all the data, what is the mortality rate in post-transplant patients that do get COVID?
So you have to differentiate between hospitalized and non-hospitalized patient and non-hospitalized patients, I don't think
you are, there we go.
Yeah, so can you hear me? Okay.
You're good for it. Go ahead.
Go ahead. Yeah, so I mean, hospitalized patient data is out there. It's about 20 to 25% mortality, pretty high. I don't know if we know the data in non-hospitalized patients. I don't think it's actually, I don't think it's high. I don't think it's any different than the general population, but they're more likely to progress to becoming hospitalized. And so if you want to look at it this way, I don't know what's the percentage of patients. I don't think the data is out there as far as telling us what's the percentage of the patient who are transplanted and progress to needing hospitalization. But once they reach hospitalization, then the mortality rate is pretty high. It's about 25%. Dr. Imlay, do you have any other, do you think that I quoted them correctly?
Sorry. Sorry, I couldn't find my unmute button and it turns out I was unmuted. Okay, I think that's about right. I think there's a variety of estimates. It definitely is important to know whether this is in hospital or out of hospital mortality, but I think those numbers are pretty accurate.
I wonder if Miklos might mention the paper actually that he and his group with all the ICU information on that propensity match study. I mean, they showed essentially similar outcomes, right?
Yes, yes. So that we have done a study in the States, like more than 50 centers, comparing similar comorbidities, and ended up in the ICU, and the mortality was 50%, as Dr. Shihab mentioned. It's pretty high, but there was no difference when we matched by comorbidities between transplanted and non-transplanted patient, but that was all ICU.
All right, if there aren't any other questions, Dr. Imlay, if you want to go ahead.
Okay, thank you very much for having me, and thank you everybody for being here. My name is Hannah Imlay. I'm an infectious disease doctor and one of our transplant infectious disease doctors. And today I'm going to talk about COVID-19 vaccination for SOT candidates and SOT recipients. I was the principal investigator for remdesivir trials at our center, but that's not what I'm planning to talk about. And this is what I'd like to cover today. So I'll touch briefly on COVID and SOT recipients. I think Dr. Shihab mostly covered that. And then I really want to focus on prevention strategies, of which vaccination is a major one. And we'll talk about different vaccines that are available, safety and efficacy, and then what to do after vaccination. I will say that questions are extremely common. As much information as is out there that is changing every day, there's even more misinformation out there that is also changing every day. And so I get a lot of questions from patients about this, and I suspect you all do as well. So COVID-19 in transplant recipients, again, I'll just touch on this. There's a variety of studies measuring mortality and morbidity in many different ways. This hazard ratio of 6 is from a large study done from the UK. And we think that this may be mediated maybe because of immunosuppression, although as Dr. Shihab says, there's conflicting data, but also because this is a group of people with multiple comorbidities, including high blood pressure, pre-existing kidney disease, potentially pre-existing heart disease. And that we know that all of these independently increase the risk for morbidity and mortality. This 28-day mortality of 19% is from the Cates et al. Study that Dr. Shihab referenced. And again, renal injury is particularly common among transplant recipients who have COVID-19, which is quite notable. We do have multiple treatment options with a list that's either being investigated and growing longer, or a list that is more available every day. But honestly, no treatment options have moved the needle enough. And so prevention, again, is key to stopping the pandemic. Prevention strategies that we know and love include vaccination, which I'll spend most of the time talking about, and then what I like to call barrier protection, which are some of these kind of tried and true public health strategies of masking, distancing, and hand washing. And I will say we're not done with barrier protection yet. So this is a summary of the currently available vaccines. 3 of these are currently authorized in the United States. 2 are not yet authorized in the United States, but my money is that these 2 will be the next that are authorized here. And I'm going to refer to them all with their company name, which I think is the typical way that people are referring to these. They all technically have their own names, but they're mostly numbers. And then at the top right here, this is a picture of a coronavirus. And what is important here is that all of these things that stud the outside are spike protein. Spike protein is necessary for binding to cells, and thus is necessary for causing disease. Without spike protein, you don't get disease. And so all of our vaccine candidates target spike protein. And that's essential to remember as we move forward. The first vaccines that were authorized in the United States were the mRNA vaccines. These are both the Pfizer and the Moderna vaccines. mRNA stands for messenger RNA, and essentially in your own cells, DNA is converted into messenger RNA, which is converted into protein. In this case, the messenger RNA that's contained within the vaccine codes exclusively for spike protein. The vaccine itself is a little bit of RNA encased in an oily coating, and essentially it binds to the cell using the oily coat. The mRNA is released into the cytoplasm, and it functions like an email telling your cells how to make spike protein, but then it dissolves fairly rapidly afterwards. And so your cells generate spike protein. Antigen presenting cells present them on the surface and educate T and B cells to mount an immune response later on. The adenovirus vector vaccines are sort of a step up in complexity. The 2 prototypes here are the Johnson & Johnson vaccine and the AstraZeneca, and there's a few more outside of the United States that are authorized. This is essentially DNA encoding for SARS-CoV-2 spike protein, and it's packaged inside of an adenovirus. And the adenovirus capsid is how the vaccine enters cells. DNA is released into the nucleus, which then becomes mRNA, which then becomes spike protein, which is then mounted on the outside of antigen presenting cells for T and B cells to be educated. It's super important to know that this adenovirus is not considered infectious. So the DNA in there code for spike protein. They don't code for any machinery for how the adenovirus replicates or infects or kills cells. And so this is not considered a live virus vaccine and is safe to give transplant recipients. The last major type of vaccine include the protein subunit vaccines. The prototype here is the Novavax, which is still undergoing phase 3 trials, but is an exciting technology. And this is essentially just spike protein connected by a nanoparticle. And again, these spike proteins would be engulfed, presented on antigen presenting cells, and then presented to the immune system. So those are the kind of 5 major specific examples of vaccines that are in our either currently available or in our near future. Anytime we're talking about vaccines in transplant recipients, there's 2 major things to consider that may be specific to transplant recipients. And those include issues of safety and issues of efficacy. When it comes to safety, the first thing that many of us think of when we talk about introducing a new vaccine is if the vaccine is intended to stimulate the immune system, could there be off-target effects of stimulating immune systems? And for transplant recipients, that often means, is there an increased risk of rejection? So far, we have preliminary data for about 200 solid organ transplant recipients, not showing a higher risk of rejection, and rather other side effects that are pretty similar to side effects incurred by the general population. And this is important for patients to recognize that you may not feel great after the vaccine. In general, these are short-lived, and that's true for the preliminary data for transplant recipients we have so far as well. And the major effects are pain at the injection site, fatigue, and headache. I find that the 4 to 9% of transplant recipients that get fevers and chills, that's kind of the most dramatic version of the vaccine reaction and the ones they notice the most. It's also important to know that long-term side effects are being tracked by the CDC and the FDA, and the CDC was the one that first identified and disseminated the information of this rare anaphylaxis identified as a possible side effect. Emphasis on rare, it's about 2 to 5 cases per million, and this pertains to the general population and is not specific for transplant recipients. So how well do the vaccines protect against COVID-19? So efficacy. It's important to recognize that either very few or no transplant recipients or other patients on immunosuppression were recruited to be used for patients in the major vaccine clinical trials. So although we have tens of thousands of patients that went through clinical trials and tested these vaccines, we don't have a lot of data in transplant recipients. So I want to start by reviewing the data in immune competent patients. This is a table of kind of the specs of each of these vaccines from their clinical trials. Please recognize the AstraZeneca and the Novavax. These numbers are preliminary and not finalized, so I'll focus on the other 3. The big things to recognize from this table are that Johnson & Johnson is the only vaccine that is 1 dose rather than 2. And the other big thing to recognize is that all of them prevent mortality 100% of the time in these trials, which is huge. In addition, the majority prevent severe COVID at a quite high rate, which is also great. I think the other thing to talk about is the 66% protection of the Johnson & Johnson against any COVID. So this means any symptomatic COVID for which you would have gotten a test and gotten a positive result. It's worth noticing that this was tested in multiple sites and the efficacy looked higher among the United States subset. But even so, these vaccines were not tested head-to-head. And so these populations that tested the Johnson & Johnson vaccine may have been in a different environment with more variants than those that tested the Pfizer and Moderna. All of these vaccines meet the predefined threshold of 50% efficacy. And that's kind of the most important point. Any vaccine that's above 50% efficacious, we think contributes to ending the pandemic. And so all of these vaccines meet that endpoint. The AST recommends to consider all vaccines equivalent to one another in terms of immunogenicity among transplant recipients. Because of that lower number, because of that 66% or 74% number, many individual transplant programs counsel patients that mRNA vaccination may be preferred, but only if they have a choice. So if they are at the stage of scheduling their vaccine and they could choose either a mRNA vaccine or a Johnson & Johnson on the same day. All major transplant programs, all major transplant societies also recommend to not delay vaccine even for a week to get a different option. So as fast as we can get the population vaccinated with any vaccine with an efficacy over 50%, That's how we win this thing. So specific efficacy in transplant patients. We all kind of went into this with the understanding that there was almost certainly going to be a higher risk that patients with a history of transplant won't respond to vaccination as well as the general population. We're starting to get some preliminary data that confirms that suspicion, although I want to emphasize that this is preliminary. This was recently published in JAMA and detailed 400 transplant recipients and only a 17% antibody response rate after the first dose of an mRNA vaccine. So after the first dose of a 2-dose vaccine series. And about 200 of those patients were kidney recipients with a 14% antibody response rate. There are several caveats to these data. The biggest one is we need to see second dose data before we know what this means. We know from other immunosuppressed populations and preliminary data from populations with cancer or the elderly population that we know that the immune response improves after the second dose. How much it will improve, I think, is crucial to knowing what to do with these data. The second thing to note is, and to question, is whether antibody is the right measure of immunogenicity. Because the immune response works in multiple ways, there may be a proportion of patients who have positive T-cell responses, even if they don't mount an antibody response. And that was not captured in this study to date. More importantly than either of those is the clinical data. So do people actually get more COVID despite vaccination than you would expect from the general population? And so we need to wait to see more data before being able to conclude that for sure the vaccine efficacy is less than in transplant patients. But we know enough from our pre-existing suspicions that we suspect it may be lower, and it could be lower by quite a bit based on other types of vaccine responses in this population. So what do we do with that? Well, one thing we can do is really optimize the timing of when to give vaccine with a goal of giving vaccine when the patients are most likely to respond. The best scenario is if you can give a whole course of vaccine prior to transplant in a relatively immune competent patient. Although they have chronic disease, which imparts some immunosuppression, we still suspect that their vaccine responses are much better than they would be post-transplant. The American Society of Transplantation does recommend waiting at least a month after transplant to get the COVID vaccine series, and waiting at least 3 months after transplants if some of these immunotherapies like ATG, alemtuzumab, or rituximab are used. It's worth noting that if ATG or rituximab are used for rejection episodes, then that should restart the clock. At the University of Utah for alemtuzumab or rituximab, which may be more potent forms of immunotherapy, we have extended that time frame to 6 months. And so really trying to optimize the time frame when patients will respond. The other strategy we can use is to vaccinate family and caregivers as soon as feasible. In Utah, we're lucky that we can all, in theory, go out and get vaccines. And the number one thing that prevents transplant patients from getting sick and dying from COVID is preventing them from getting any COVID. The best way to do that is to vaccinate their immediate community as their family, and also to vaccinate as much as possible the greater community in the state of Utah. The last thing here is that it's important to recognize that transplant recipients won't all act the same way. And when we talk about, say, 50% vaccine efficacy, for example, that doesn't mean everybody will only have half of a response. That really means that a proportion of patients will have a full response to vaccine, arguing that those patients should definitely get vaccinated. A portion of patients may have a partial response to vaccine, meaning that that response may not last very long, or that it may be overcome by an overwhelming amount of SARS-CoV-2, but would still argue to vaccinate that portion as well. And some patients will have no response at all. The problem is we can't predict who will fall into each of those groups. And so it still makes logical sense to vaccinate all recipients as quickly as we possibly can. To speak to that, many patients will ask, can you measure whether I'm one of the ones that have a full immune response or a partial immune response or no immune response? And of the commercially available assays for testing immune responses to SARS-CoV-2 are really antibody tests. So can you check my antibody? The CDC and American Society of Transplantation currently state that they do not recommend routine checking of antibody responses outside of a clinical trial. And they do that for several reasons. The first reason is that it may be confusing based on the number of assays that are commercially available. So there are multiple assays on the market that have multiple targets. One very popular one is the anti-spike antibody. Another very popular one is the anti-nucleocapsid antibody. Among patients who have been vaccinated, they would be expected to have an anti-spike antibody because all vaccines that are currently available produce spike Ts so that your immune system can learn how to respond to it. So that would be something that people would respond to. However, nucleocapsid antibody tests, because none of the vaccines contain nucleocapsid proteins, all the results of anti-nucleocapsid antibody tests would be negative. And this can be extremely confusing, especially when it's not super clear what the antibody, how the actual antibody assay measures. In addition, the protective threshold of even the proper anti-spike antibody test is unknown. So if I check my antibody and it's a 4, I know it's better than 0 and it's not as good as 10, but I have no idea if that means, am I protected? Am I partially protected? Or am I really not protected at all? We simply don't have those data. In addition, what I previously said about T-cell immunity, where we don't know that antibody is the only way that people develop immunity to SARS-CoV-2, and checking an antibody may not tell the whole story. Lastly, and maybe most practically relevant, is that if you have a low or negative result, it doesn't change your behavior strategy because everyone should still be masking in public, for example, and I'll get into that a little bit later. But it also doesn't change your vaccination strategy. So we have no data now about second rounds of vaccine, about booster doses of vaccine, or about high dose levels of vaccine. We hope to have those data in the future. We suspect that there will be studies looking at the feasibility and the efficacy of such strategies, but we don't have that information now. And there are limited numbers of vaccine, and so patients can't go out and get multiple rounds of vaccination. So truly knowing some of this information does not necessarily change what we can do about it. I want to take a quick minute and address the novel variants because this has been discussed quite a bit. Variants in the SARS-CoV-2 genome occur over time as mutations build up. And once mutations build up in things like spike protein, or mutations build up in proteins that are suspected of increasing the ability for transmission or decreasing the ability for the immune system to respond, they are labeled variants of concern. Currently, we have 3 variants of concern that are circulating globally. The B.1.1.7, also called the UK variant, which is most prevalent in the United States of these 3. The B.1.351, also called the South Africa variant, and the P.1, also called the Brazil variant. And you can see here, this is the B.1.1.7 cases that have been reported in the United States. This was accurate as of Sunday, so who knows what it looks like now. But in Michigan, you can see, looking at their state cases, that they've started to go up, and we think that this variant is more transmissible. So how protective are the COVID vaccines against the variant strains? This may be a big deal if, in fact, the B.1.1.7 takes over the United States. Unfortunately, we don't have clinical data for all vaccines against all types of variants. So for example, the Pfizer and Moderna were never tested in clinical trials in places with a high proportion of variant SARS-CoV-2. And so we simply don't have enough information about those vaccines. We do know that for the B.1.1.7, both the Novavax and the AstraZeneca vaccine looked like protection was fairly similar against variant strains as non-variant strains. For the B.1.351, we can see that efficacy did drop for the Novavax and the J&J into the kind of the mid 60%, although both higher than the 50% cutoff, but that the AstraZeneca dropped quite low, and it was about 10% efficacy, so much lower. And then for the P1, the J&J has been the only vaccine tested against patients with those circulating variants, and the efficacy was around 68%. So we know that efficacy drops. For the most part, it has been over 50% of the tested vaccines, but we will need to get rapidly more information about all vaccines that are available, and not just the Novavax, J&J, and AstraZeneca. So in light of all of that information, variants, responses to vaccination, et cetera, what can I do once I'm vaccinated? Well, the CDC guidance is really targeted at immune competent patients. And their most recently updated guidance says that you can, if you are fully vaccinated, gather indoors with other fully vaccinated people without a mask, gather indoors with unvaccinated people from one other household without masks, unless any of those people has an increased risk of severe illness, for example, an organ transplant. But you still need to mask in public, mask or avoid multi-household gatherings, and delay travel. What about transplant recipients? So this is different for transplant recipients for all the reasons that we talked about. Patients should still wear masks, have good hand hygiene and physically distance, even after vaccination. And this is something that every transplant patient should be counseled against. The CDC approach of unmasking around other households is not recommended in transplant recipients. And transplant recipients will be able to return to normal, but only after community spread is controlled and community spread is minimal. So to summarize, transplant recipients, transplant candidates are at high risk of severe COVID-19. Both of these groups should be prioritized for vaccine. All currently authorized vaccines are generally safe and also safe for transplant patients specifically. Transplant patients may not respond to the vaccine. And so other prevention measures such as masking, other forms of barrier protection must continue until community spread is minimal. I want to thank everybody for being here, and I will take any questions.
So folks, if you'd like to ask a question, now's a good time to unmute your microphone, speak up, join the conversation. You can also use the chat feature, type in a question or comment, and our presenters will have that information.
And so I'm actually going to take the first stab at it. And actually, my question is to Dr. Shihab. We spoke a lot about what to do when it comes to immunosuppression when a transplant patient gets infected. And most recently, we put together a small initial guidelines that, based on the best data available at the time. And I want to see if you can speak to that for a minute.
So yeah, thanks for the question, George. I think, based on the recommendation of the EST, is that do not lower the immunosuppression unless the patient is very ill, because like you also pointed out many times before, it's a fine balance between viral replication and blunting the immune response. And it seems that although it works against the viral replication, it tends to work favorably against blunting the host immune response. So as a net, it has a net zero effect, So the way I'm approaching it now is that I wouldn't lower the immunosuppression unless the patient is in the ICU, is critically ill, to the point where they have other infections, not just COVID, but other infections also, where lowering the immunosuppression may make a difference.
Sounds like Dr. Molnar has a comment as well.
A question. It was great talk, both of them. Thank you so much. For Dr. Imlay, do you know any data about whether the immunosuppression is affecting the COVID vaccination, and whether we should say the patient stop the MMF 5 days before the vaccination, just be more effective? Do you think this is a good thing to do, or should we wait more data?
So I'm definitely in the camp of waiting for more data. I think there are some logistical considerations. For example, if you tell them to stop your MMF 5 days before vaccination, is that true for the whole vaccine course? If you're getting 2 doses 3 weeks apart, because that's actually that's a lot more than 5 days. The only data that we have about immune responses are from that JAMA study, which, as I mentioned, is really preliminary. It did look like patients responded less well when they were on antimetabolites versus other forms of immunosuppression. But again, I think we need to know the final data before actually changing what we do for patients before vaccination.
Thank you. Thanks.
Looks like we have a question from Deanna. Deanna is asking Hannah, why do we advise waiting 6 months to get the vaccine after transplant here at the University of Utah?
So our recommendations as a transplant center are really dependent on what types of immune suppression the patients have received. So for example, if they've received rituximab or alemtuzumab, extending that period of time, as opposed to if they received ATG induction. But it doesn't, we don't recommend 6 months for all patients. It really is dependent on the type of immunosuppression that the type of induction immunosuppression they had. And then again, if they received immunosuppression for any other cause, including rejection subsequent to transplant.
I actually have a question, Dr. Imlay. I wanted for you to speak to a little bit to some of what we know about the non-antibody related immune response. Specifically, the data that some of the population have some natural immunity to this virus, as well as the possibilities that this could be the case with some of our transplant patients after vaccination.
Yeah, so the number of studies that directly address this, again, they are quite few. So I think that's the preamble that I have to say before every question. If I forget, just remind me for any further questions. There are a couple studies that have now been published about immune competent patients. And if they've previously had SARS-CoV-2, then one dose looks very immunogenic. It's sort of as if your first SARS-CoV-2 infection was your first dose, and then the first dose of the vaccine was your second dose, and their immune responses after one dose of vaccination look quite strong. The problem is that I think any of that cannot be extrapolated for transplant patients because that lasting immunity you may assume it's there, but it may actually not be there. And so even though transplant recipients have had many transplant recipients have had COVID-19, we can't assume that they generate a similar immune response. In some of those data, looking at immunocompetent patients, we can see that looking at their immunogenicity to their natural COVID infection, some of them have a positive antibody, some of them don't have a positive antibody, but have other markers of T-cell immunity. And so we don't know the proportion of patients that will have, on a large scale, that will have T-cell immunity versus B-cell immunity versus a mix versus both. But there are probably some that's not overlapping. But I think we simply just need more data in transplant recipients to be able to extrapolate a lot of those data.
It looks like Dr. Campson has a question, which has been a thorn to us for a while, and Hannah got many phone calls about it, which is basically the prolonged shedders, the people who are trying to donate a kidney or live donor kidneys, and they keep just shedding virus. If you can speak to that for a second.
I can speak to that, but I will say that we have no good answer for this. We know that people may shed what we think are bits of DNA or bits of RNA rather than active virus, and we think that people will shed them for a long time. The CDC, kind of looking at all the data, sort of recommended that most people don't shed them for longer than 3 months. So if you get people shedding for longer than 90 days, you need to start considering that this may be a recurrent infection. It doesn't necessarily mean that that is a recurrent infection, simply that the physicians need to consider that may be the mechanism for why they're still testing positive. However, we have seen people test positive for much longer than 90 days and have no evidence of new infection, no evidence of new symptoms, no evidence of new exposures. We do, however, see rare cases, and this is unusual to be in donors because donors are by and large immune competent, but we do see rare cases of patients who have long active COVID, shedding active virus, actively symptomatic for months, typically in patients who are quite immunosuppressed. So we've seen this in a couple of our cancer patients. We've seen this in actually some of our kidney recipients who've received rituximab or other immunotherapy during their course of COVID. That in general is pretty unusual. We're more likely to be faced with this scenario where donors are still shedding and testing positive and have to make that decision of whether it's RNA that does not reflect active infection, and thus they're still good to be donors or not. And that's a hard decision to make. But using clinical clues, using antibody testing, so patients who've developed an antibody are more likely for this to be not active shedding. And then very occasionally we can look at some of the test characteristics, where it was tested from, et cetera, to help make that determination. I think there's no good answers there though.
We're going to take one final question from Isaac Hall, and then we will go ahead and go to our closing statement.
Awesome. So I know that there's not much time, but maybe this is actually appropriate. Either Hannah, maybe especially, could you model for us, how do you talk to patients, you know, that are hesitant, or their families that are hesitant? Like, do you have a 30-second sort of spiel that you give to people who are really hesitant about it?
So I've talked to a lot of people, and everybody is very different. And a lot of people means family, means friends, means immunocompromised patients, et cetera. And I think the biggest thing is, before the 30-second spiel, I have to know what their specific concerns are. A lot of young people are sort of thinking, you know, either I've had COVID-19 or, you know, I won't die from COVID-19, so why do I need to get it? And that spiel is very different from someone like that than someone who is a transplant patient who said this has never been tested, and someone like me, why should I put myself at risk to get the vaccine? I think a lot, you know, my 30-second spiel is sort of a rehash of that talk, but really emphasize from the transplant patients that this is definitely higher risk, that we need vaccination in everyone to actually keep this from happening. And that in the data we have, and also extrapolating from many vaccines that we already have, we have a strong track record of safety with vaccinations. I think it's also helpful to emphasize just the vast numbers of people who have already been vaccinated, which is in the millions of people that have been vaccinated without huge side effects. So that's maybe an insufficient answer, but that is generally what that spiel covers.
Great.